with a diagnosis of extensive ductal carcinoma in situ. She's a 41-year-old para 5+0, first presented with a history of breast lump in July 2016 at Kericho District Hospital, where lumpectomy was done and sent for histology. Histology showed high-grade ductal carcinoma in situ with comedonecrosis and cancerization of one of the mammary lobules was noted. She was referred to oncology review at MTRH. She came in August 2017. Rebiopsy was done on the lumpectomy site, which showed morphological features consistent with ductal carcinoma in situ. Nuclear grade 1. Patient was advised on MRM. She declined and she was lost to follow-up. Patient came back in December 2017 to surgical outpatient clinic with a right breast mass T3N1, and she was sent to oncology clinic for biopsy, restaging, and immunohistochemistry, and probably neoadjuvant chemotherapy since the tumor was unresectable. Biopsy was done in December 2017, which showed extensive ductal carcinoma in situ. Patient was then started on neoadjuvant chemotherapy on 30th January 2018 and has so far completed 6 cycles of SE, that's doxorubicin and cyclophosphamide. Last cycle was done on 15th of May this year. Currently, the patient has no complaints. Past medical surgical history was unremarkable. Personal socioeconomic history, she's married with 5 children and she works at the estate factory as a casual laborer. There is no history of chronic disease in the family. She's an NHIF beneficiary and she's a contributor. Review of system, unremarkable. Summary: a 41-year-old para 5+0 presented with a breast lump in 2016. Lumpectomy done, which showed a ductal carcinoma in situ. Patient was advised on MRM in August 2016. Declined and lost follow-up till 2017 when she presented with a tumor T3N1 tumor to SOPC clinic. She was sent to oncology for neoadjuvant chemo since the mass was unresectable. So far, she has finished 6 cycles of chemotherapy. She's due for surgery. General exam, she's on a fair general condition, EGOG 0. She was not pale, she was not jaundice, with a right axillary lymphadenopathy 1 centimeter. Vitals were within normal. Local exam, breast symmetrical, surgical scar on the right breast, palpable mass at the right outer quadrant 2 by 2 centimeters, smooth not attached to the skin and tender, adherent to the chest wall. She had a palpable axillary node on the right side. Left breast was normal. These are the histology results which was done. This was the first histology after lumpectomy in 2016 in the district hospital. Microscopic examination shows quite a patchy with other breast lobules who are completely uninvolved. Also noted is an expanded terminal duct lobular unit displaying high-grade ductal carcinoma in situ with comedonecrosis and canceration of the lobules. There is no definitive morphological evidence of stromal invasion. Conclusion of the right breast lump excision biopsy which showed high-grade ductal carcinoma in situ with comedonecrosis and canceration of one tumor lobule was noted. Pseudolactational change is noted in the background. There is no definitive evidence of stromal infection led to examination. Examination of the entire specimen was mandatory to exclude foci of stromal infection. Another histology which was done at MTRH in 2016 August. That was a skin surface measuring 3.5 by 1.5. Microscopy section showed breast tissue predominantly composed of benign ducts and lobules. Focal area with micropapillary and cripiform ductal carcinoma in situ. Nuclear grade 1 is identified. The myoepithelial layer is highlighted by asthma, no evidence of infection. The ductal carcinoma in situ is not seen on the margins. Surrounding areas show foreign body, giant cell reaction, suture craniomulus, and fibrosis with hemosiderin-laden macrophages. A diagnosis was made of a ductal carcinoma in situ, nuclear grade 1. After this histology, the patient was advised on MRM, which she declined, and she got lost to follow up. These are repeat histology, which was done after she presented back to the clinic in 2017, December. Microscopic sections from all three show breast tissue exhibiting extensive ductal carcinoma in situ, nuclear grade 2, and mainly comedonecrosis and cripiform patterns. No evidence of invasive tumor in the biopsies examined. Metastatic workup was done after chemotherapy, was negative for metastasis. Point of discussion, best surgical management or best management for this patient. Thank you.
Is there any challenge with the surgery?
Sorry, come up again.
Are you having any challenges during the surgery, or is there anything which is like obstructing you from doing the surgery?
No, I just thought that this was, Sylvanas, maybe you want to turn off your mic and I'm talking. Thank you. I thought this was an interesting case because this is not the usual algorithm for DCIS. You don't usually do an MRM. She's booked for surgery tomorrow. I plan on doing it. I don't think I'll have any issues. She's very small breasted and I can, the mass is pretty discreet. I don't think that there's going to be an issue with operating on her. I just thought that this case, one, usually DCIS is not a palpable mass. And so her case has been unusual because in repeat pathologies, it keeps on failing DCIS. Although the original one, I'm not really sure why it says cancerization of the lobules, if that means it's beyond the DCIS criteria. So I just thought it would be good to discuss because ultimately, I remember her case actually when I first arrived to Eldoret, and there was a lot of discussion, and there was even discussion on not operating on her, but obviously her disease progressed and she needs an MRM now.
Okay, and just to comment on the pathology, they say it's a grade 1, and at some point they talk about communal necrosis, which shows features of probably a more aggressive tumor. Probably the site of biopsy, that's where they saw the core biopsies, that's where they actually saw DCIS, but it looks more of invasive carcinoma, kind of.
So from the pathology aspect, I think the initial one, which was done in 2016 September, was more of a nuclear grade 1. By then there were no comedonecrosis. It was largely a low-grade ductal carcinoma in situ, which was more of a what was the residual from the previous lumpectomy. But then that was the one that was done in December, is the one that is nuclear grade 2, which is largely an high-grade lesion, the one with comedonecrosis and cribriform. But then still, it's still unusual to have a solid lump.
So this is actually July 2016, the one from Lancet.
Yes. And
at the time, I think they said the margins were negative, if I remember correctly.
yes.
And there was a lot of discussion, I think, because of the labeling of DCIS, but not really reading the chomionecrosis, which is a bad marker on DCIS, as well as that cancerization, which makes me concerned. And so there was a lot of back and forth at that time about whether or not to pursue further surgery or any treatment, because if at DCIS alone, you can actually, the algorithm, you can get away with just a lumpectomy at the time as long as the margins are negative. And I think this is sort of where her care got a little confusing.
So this was in July 2016?
Yeah, and so this report came out and she came to SOPC. At that time, about 3 weeks post-operatively, she had a positive lymph node. And so there was a lot of discussion on what to do next. She got an FNA, but when she was sent for FNA, they could not feel the lymph node and they FNA'd the scar, which came back with malignant cells. This led us to rebiopsy the scar site, which is the second, if you can bring up the second histology. That's this specimen then.
Around August, yes.
Yes.
Because looking at the two, I remember, I think I must have seen this even without knowing the previous histology, the one that had been reported as DCIS. And the challenge, even the one for Lancet, irrespective of the fact that they mentioned one of the lobules was show cancerization. But then again, they've gone ahead to do one of the myepithelial markers. If it's intact, then there is no, you cannot say it's invasion, because as long as the myepithelial layer is intact, then it's not an invasive tumor. And it's similar one as well to this one, because I remember struggling, wondering whether to call it invasive or not invasive. And then the smooth muscle marker, which is also a myepithelial marker. Asthma it does similar role with the P63, and you could still see it's intact around. So you have cells that look atypical, almost neoplastic, but then it's surrounded by myepithelial cells. And then again, the last one that was done, the core biopsies, it was mentioned that it was done in multiple, like it's not in one site. And usually when you get DCIS, but it's not like it's involving multiple ducts and even almost quadrants, then it becomes almost an extensive. But then again, all these, usually the challenge that we see when reporting such is you get to one and you don't know what was the previous one. So this is one of the challenges. But by far, everything is pointing towards a DCIS, but then the clinical picture, you said, doesn't point towards.
Yeah, because usually DCIS does not correlate with a physical mass on exam. It's usually a radiographic finding that you chase afterwards.
What about the lymph node? How is it, like the lymph node from 2016 to now?
So I think the lymph node has been on and off, and I think it's actually very hard because I felt it on exam initially, and then when I went back to confirm, it had rolled away. So I think that's what's brought difficulty in her exam as well with other people who have seen her. It's there because on imaging, on CT scan, they actually see the lymph node as well. So, I mean, I think this is unusual because it's very rare you do an MRM for DCIS, but also at the same time, DCIS is usually not a palpable tumor that you can feel. I think probably this is, to a degree, a very aggressive DCIS or invasive ductal carcinoma that we just have not been able to correctly identify on pathology or see very clearly on pathology. And so I just wanted to bring it forward because the standard for DCIS is usually not MRM. But in her case, with her recurrence and the story, I think she needs an MRM at this point.
Yes, I agree with you totally. And the fact that she has a lymph node also, it's probably it's a more aggressive disease than what we got on pathology. It could be the site of sampling, which could be the issue. Thank you.
What do you mean the site of something?
Sampling, where they took the core biopsies. It could be like multiple areas of DCIS and also with a component of invasive carcinoma. So where it was sampled or where it was biopsied, they could have biopsied an area of DCIS.
I think that, yeah, that's my suspicion as well. I think
Yeah.
part of me is a little frustrated because if she had gotten the MRM back in 2016, we would not be still talking about her, and maybe her prognosis is worse now because we've let 2 years lapse. But at least she was responsive to neoadjuvant, and she's ready for surgery now.
Okay, thank you.
I think that leaves us pending with the how to manage the DCIS, because I know we have 1 or 2 patients who the surgeons have had problems deciding what to do. Others want to do radical mastectomy, and others think you should just do an excision. So it means that you can actually get a biopsy of one place and it is a DCIS, but another place an invasive carcinoma. Is that what we are saying?
I mean, I think you have to correlate it with the exam. If these women you're talking about has a mass, it's unlikely that it's DCIS alone, I think, is especially in this setting. I think it's very hard to correlate the protocols because the protocols that come from the West, it's all mammography lesions that they find. They're not palpable masses that prompt the workup.
Uh-huh.
I also think if you have a palpable mass in our population, it will be safer to just do a modified radical mastectomy. And you know, remember when you do a lumpectomy, the patient must have radiation afterwards. And sometimes this can be like an obstacle to some of our patients. So in our particular population, I think it will be a little bit of a risk to just do a lumpectomy or a DCIS. And then in MTRF, you have mammography. I think there's a mammography machine with the tomosynthesis. So you can actually do 3D mammography. But just access to that service and all the other things which come around and all the complications, it will be much safer to just do an MRM and get the lymph nodes and look at them also.
I agree.
Okay. How often are we using those mammographs? Because I know in JOTRH you also have a mammograph. But I wonder who reads them. Are they experienced enough? And will you believe whatever is read? Because I don't think any of your radiologists
yes,
train in
yes,
mammography. You have new machines. You have new machines which are installed. Yes.
Yeah. So generally it should be the radiologist, but I think also as clinician we should be able to look at it with the BIRAD system from BIRAD, is it 0 to 6, where clearly you can see tumor. But it would be good to work with the radiologist. Yes. Okay. So BIRADs 1 to 3, those are usually, like 1 is something which is not obviously a tumor. 2 is not suspicious. I think 3 is in between, and anything 4, 5, 6, BIRAD 6 is suspicious, and actually 6 is obvious tumor on radiological examination. But we need to work with the radiologists. Actually, myself, I've not seen a lot of mammograms. Probably some of those patients who come and they're just suspicious of tumor in their breast and who are 40 years and above. I've sent, this year I think I've sent about 4 or 5. And the last time I walked by the radiology department, when we saw the mammogram, the guy was just seated there looking at the machine, and yeah. So I think maybe we may need to do more screening. Yeah, so that's how it is. Probably when we do the cancer campaigns, we should advocate for more mammographies and ultrasounds done on the breast. But you know, the problem that it also involves cost. So this is probably what keeps patients away. Thank you.
Yeah, but it's not also cost. Are people ordering? Because I know the mammography. This hospital, people went out of favor, and so they don't know who to send.
Sorry, Dr. Ganda, we didn't hear you.
So we didn't get you.
Yeah, what I'm saying is we might need to come up with protocols and send them out to doctors and clinicians, because most of them trained without using a mammography ever. And so when you're in the oncology unit, most of the time what you are getting is cancer already. You will rarely get women who are coming for screening. Those are women coming to the outpatient departments. Hello, did you get
So
me?
Greg, I will say, like, whenever you carry out some of those campaigns and screening drives, generally for ladies under 40 years of age, I will recommend ultrasounds because they have firmer breasts. And those ones who are above 40 is when you can actually request for a mammogram to see. Yeah.
Okay.
So the best chance for us to start using the mammography is during the screening campaigns. So I think in October is Breast Cancer Month. We can roll that up. In MTRH, you have a daily breast cancer screening program, which is ongoing, and I think there are quite a number of patients who are screened. Just that I've also not seen a lot of
mammographs.
I think the other question I wanted to bring up with this case was sentinel lymph node biopsy, because with DCAS, usually you do a sentinel lymph node biopsy. I know I haven't been here for a while. I don't know where we are in the process of potentially setting that up.
We haven't made much progress as well because we still don't have a crash that. No, I'm wondering about, you mentioned earlier that the patient was against mastectomy initially. Has she changed mind?
Yes. So I actually remember telling her after all of these FNAs and 2 DCAS diagnoses that the best thing for her would be an MRM, and then we lost her for follow-up for 2 years. And I think because the mass regrew, she was amenable to neoadjuvant, and when we talked to her on Thursday, she said she'd be willing to have surgery tomorrow. So that is the plan.
I think besides this case, there was another case previously that I think it was from Kakamega or something where, okay, from the core biopsies you could see again it's just in situ, but then it's said to be a 6 centimeter. And even a repeat one was reported again as PCIS. Still wondering about the proportion of this DCIS that can present as a lump vis-a-vis the sampling.
I think that's a sampling issue then. I think if there's a mass, probably if you get DCAS on pathology, you still have to assume it's invasive carcinoma. But I'm not, I'm learning this, I think, as I'm talking. I don't know. It's not my experience in training, definitely, but this is a different setting.
Me too, it's a similar one. When someone in the request form mentioned that this is a patient with a breast mass, this and this and this centimeters, and then I don't see the invasive component, it becomes difficult to conclusively call it DCIS. In fact, you do even want to recommend some repeat sampling or something like that.
And even for the clinician, when we're seeing the patient and reading the pathology, it becomes a very difficult decision algorithm as well. But I think that's why these tumor boards are helpful to discuss this. I think we can go on to the next case. It's also a breast case that I saw last week. Go ahead, Sylvanus.
Patient PW, female, 46-year-old, seen surgical oncology outpatient clinic on Thursday with a diagnosis of Paget's disease, invasive ductal carcinoma. That 6-year-old female presented with a breast nipple ulceration and retraction in February 2018. Prior to that, she has been treated severally for breast abscess with no response. Core biopsy done microscopic examination showed Paget's disease of the nipple, a focus of invasive ductal carcinoma with nuclear grade 2 is seen in 1 out of 14 submitted tissue cores. In some cores, there is a presentation of epidermis with features of Paget's disease of the nipple. She was referred to MTRH for oncology review and management. On examination at MTRH, she had a left breast autoamputation of the nipple with ulcer in duration palpable mass centrally 5 by 5 centimeters with a single axillary lymph node. Metastatic workup showed CT scan just showed a 5 by 3 centimeter left breast mass with no metastasis, but the patient could not palpate the mass. She was started on chemotherapy neoadjuvant AC on 26th of March 2018. So far, she has done 4 cycles, clinically marked improvement, no palpable mass. She was referred for surgical review. Metastatic workup post-chemo, an impression of a left breast ill-defined diffuse and enhancing lesion measuring 3 by 1, 8 by 8, 3 by 8 by 8 with areas of encroaching upon the lateral part of pectoralis muscle. Multiple suspicious axillary nodes, impression of a left breast mass with axillary nodes as described, suggestive of breast carcinoma, which was known, with a likely metastasis. No pulmonary abdominal nodal or osseous metastatic signs. CT scan abdomen was essentially unremarkable, with part from mild gastroduodenal, mild thickening with increased enhancing and mirrored edema. Currently, the patient has no complaints. She was on a fair general condition, not pill, not jaundice, not sinus, EGOG1. Review of systems were unremarkable. Local exam, breast symmetrical, right breast, no palpable masses, no nipple retraction, no discharge, no lymphadenopathy. Left breast, ulcerated nipple, right, no palpable masses, no palpable lymphadenopathy. Dr. Coney will summarize the patient.
So I think, again, I'm not sure how accurate the information is before I saw her. I first saw her last Thursday. So according to the patient, when she presented a couple months ago, she had never had a mass. It was just an ulcerated nipple that had sort of auto-amputated on the left side. And I think that shows because they did 14 core needle biopsies to do the workup. Because usually if you have a discrete mass and you're able to get a core biopsy, you only do 3. So it's unclear to me whether she ever had a clear mass that was palpable on exam. The imaging at that time showed a 5 by 3 centimeter mass. And when you look at the imaging, it's not a discrete thing. It looks actually like breast density, but has more inflammation around it. It has a different Hounsfield unit to it than the other breast, which was just normal breast density. I actually reviewed this with the radiologist. So that's, I think this is Paget's, and maybe in Paget's you don't really ever have a clear mass. It's more of an infiltrative disease in the breast that you see on CT scan, and that's something that I'm not really clear on. She underwent neoadjuvant, and she said the neoadjuvant did improve the symptoms in that the wound dried up. But as she said, there's no mass, and there was no shrinkage of mass because of the neoadjuvant chemotherapy. So now she comes with repeat imaging after 4 cycles. It did slightly improve because the wound dried up with the neoadjuvant, but then on repeat CT imaging, now this mass, which is not palpable on exam, has extended from 3/5 to 3/8. So technically that means that most likely the neoadjuvant's not working. Again, this is very confusing because she has no palpable mass in her breast. So I'm not sure the way forward for her. And I don't know, maybe this is just, I've tried to read up a little bit on Paget's, but I don't know if this is just how Paget's presents. It's just more of an epithelial manifestation that you see. It's also a little strange because of the 14 core needle biopsies, only one of them showed the invasive ductal component.
Just to point that out, there's an invasive component of invasive ductal carcinoma component in the disease. So basically, Paget's disease, you'll want to manage it surgically, and that should be the method of management. But in this case, with the invasive component, invasive ductal carcinoma component, she may actually benefit from the neoadjuvant and surgery, followed by after the, probably you can discuss it about the mastectomy. Then we can look at the specimen in a more comprehensive way.
So my question is, because this is not a palpable mass, it's only on the CT scan that we see it, it's actually increasing in size with neoadjuvant chemotherapy. She got 4 cycles of AC, and it's increased in size. Unfortunately, we don't have tumor markers, so we don't know more specifics about the behavior of this tumor. So the question is whether or not we do surgery now to do an MRM. We may not get we may not get good margins because this mass is enlarging, to switch chemotherapy regimens and see her response, but you can only see her response on imaging, so she'd have to get serial CT scans, or to complete chemotherapy.
Yeah, hello? She's had 4 cycles of AC.
Correct.
Okay, and it's 8 centimeters in size.
This is based off of CT scans. It's not clinical exam because there never was a mass. She clinically improved, she said, because the wound at her nipple dried up. So it's not very clear whether she's responding to the chemo, because on imaging it's getting bigger, but clinically she says it's helped dry up the malignant wound.
Yeah, we will recommend maybe she does 4 cycles of docetaxel ACT treatment. If you feel that will help us with the surgery, we can do that. We can do like 4 cycles of docetaxel, and then she goes for surgery. And then we can be able to see if we can get clear margins. The reason why we are giving chemo, in my opinion, should be just because of the invasive ductal component, not for the Paget's disease. For the Paget's disease, afterwards, if there's a positive margin, we can go ahead and do some radiation treatment to the scar.
My question is, I think you've seen more of this than I have. Does Paget's usually present massless and it's just a wound at the nipple? Because I've assumed that it was associated with a wound at the nipple.
Yes. It actually just, in most cases, the most cases that I've seen will be a wound at the nipple, and it involves the skin only. So it's infiltrating into the skin. You don't get a lot of masses which are palpable and all that, but you do get in some cases. So it is possible that it can be.
Okay,
Sorry?
I was saying from the histology aspect as well, Paget's would like mean literally you have like in situ carcinoma along the epidermis, not invading through the basement membrane. But then again, from the ones I've seen, usually most of the time they start the in situ component, the DCS, or an invasive component start from one of the lactiferous ducts and then spreads to the epidermis. And usually does it just begin from the epidermis. So from even some of the mastectomy specimens that we used to get with an ulcerated nipple and suspected Paget's, we usually tend to sample almost all the region around the nipple. So we process almost all the central region of the breast. And you process, the more you process, the more chances of picking a small, tiny focus of invasive carcinoma. I guess that is one of the reasons, because usually you tend to find small focus of either an invasive or an in situ component on the ducts themselves that are spread to the epidermis. So sampling is usually one of the key ways. In fact, for such a case, again, even the gross mastectomy specimen, you can't feel a lump, but you usually process around the nipple, everything, and then with those you tend to get a focus of in situ, like invasive component.
So, I mean, to me, I mean, I don't know if surgery is the best route, although the CT scan with the encroaching cancer to the pec is a little concerning, or if we should switch her to another agent and try that for 4 cycles and re-image her.
Yeah, I mean, if we are unable to, if you feel that you cannot surgically get any clear margins, we should actually proceed with the treatment, 4 more cycles of taxane-based treatment.
Okay, I think we'll refer her to that then.
Yes.
Hello?
We
Hello?
can't hear you very well, Dr. Ganda.
Sorry. Saying, what is the fee?
I think we've lost you, Dr. Ganda. I'm sorry, but we're not able to hear Dr. Ganda. Is there any other opinions, questions?
Hello, I think we've answered most of the cases. And sorry, I was not there physically today, but I'll make sure. I'm actually getting on my leave. So, but we'll still try and keep the tumor board active. Thank you.
So I think we will stop there for today. Thank you for joining, everyone. And I think today has been a good interactive session, and I would like to appreciate everyone. And please encourage other people to be joining us so that we have more opinions, more interactive session like for today. So thank you very much. I think we will stop there for today, and we'll continue next week. So thank you very much. God bless you.